right back to them what they just told you. You want me to leave? I hear you. And then this idea, like someone says you want me to leave. It's so frustrating to have no control who comes in here. I get it. But it's so aggravating. It's so shitty.
No.
Right. Well, like, sounds good. So yeah, so the waters. Maybe we can do better with our language to be more consistent. But yeah, that's a emotion naming in this rubric. I see you won't talk to me. I can leave you alone, but I just need to know why you don't want me to speak. And that actually, for me, has been the most helpful. Like you can say, look, I get it, but it takes the edge off a little bit. Like you don't have to talk to me, but can you tell me why you don't want to talk to me? It makes it more neutral, makes it more objective. It's not about me and you, it's about this something else. There's a reason someone else takes away the pleasurable intensity, which I would consider clarification. I don't know if the concept. Like I use my airport security example. And then this is just an example of simple limit setting. Here's why I'm here. We have to understand you. Here's why I'm here. And then if you leave before we can talk, this is when I need to call security, and that's the limit setting. Yeah, then finally to wrap things up, this idea of debriefing. I think this might need to be discussed on a more administrative level than as opposed to here. But this idea of how do you gather everyone who's involved in this patient. The idea of the floor is a community essentially, with nurses, PCTs, all these people involved in the patient's care. And everyone who's involved in their care needs to know about what's going on with this patient, so there needs to be time set aside to reflect everyone.
You're not sticking to time schedule, huh?
But yeah, but I'm going to maybe abbreviate that.
We discussed it.
Go back
Did
to
you?
slide
Okay.
four. Go back to trust. Trust. So my sense is that there are two reasons why people get agitated, aggressive, violent. One will be either they get really pissed off about something, they don't feel that they're going to get what they need, but a lot of people, especially the ones who are delirious, or someone's hallucinating, things like that, they're very frightened. So I think there are two main problems. One might be fear, this idea of broken trust, but it's also they're scared shitless and they need to get out of here. They're feeling paranoid, they're feeling trapped, and so I think fear is a big issue, and I think acknowledging that, when you briefing, you look afraid, you seem to be very afraid. Let me be, I'm here to make sure that you get what you need and that you're safe, so that kind of safety is an issue. And if you go back a little bit further to, you have the crisis spectrum.
Mm-hmm. Yeah.
So for instance, delirium with narcotics, delirium with hypoxia. I don't understand why there would be a differentiation. Are you saying that there's a delirium in which you have hallucinations and delusions, which makes you scared, this and that? Is it the delirium where you're hypoxic and you're impulsive and you lost control? It's really like the features of the delirium that are critically important rather than the etiology, I think. I don't know is that what you were trying to convey?
So these are just examples, but I guess what I'm just trying to convey is a sense of everything existing on a spectrum. So there are going to be, some deliriums, not necessarily specific, but that's just my experience.
So maybe like mild delirium and severe delirium.
Or maybe delirium with delusional hallucination. So maybe use that instead of the specific examples.
Instead of the etiology.
Okay.
Delirium.
Right, and in this one where you have like loss of identity, I really don't even know what that means.
I guess it's sort of like
you mean that like having an existential crisis, like who am I? Or
This person's not acting like themselves.
Huh?
this isn't my dad here. This is someone else.
They're not acting like they usually do.
Well, I'm not myself, so it's
Yeah.
So it's behavior out of character.
Sure.
I mean, let's use words that are simple but convey the meaning, right?
Yeah.
And I think to Brown's point of the, how much time you take with this kind of a model versus focusing on the patients that are really going to be called for, they're not going to be called behavioral response team for someone who's having trouble coping and has
So-
overvalued ideas. They're going to get called for the person who's got agitated and screaming and all that. And they're already probably down at the bottom.
Exactly, yeah.
Maybe, or maybe not. Is that what you're saying?
Yeah, I'm saying like when you write about the scene, maybe I should lead off with this, that they're already at the bottom, like they're already pretty distressed, but like as they get better, it's not like you're gonna solve the problem. You're gonna maybe get a little bit of leeway, you might be get a little groundwork, maybe they're metabolizing medications, and then, wow.
So where, on this graphic, where would you say behavioral rapid response team comes in?
Right at the beginning.
There?
And their goal is to get up.
So that wasn't clear to me.
So red and below, you mean?
Right, but as they're intervening, there might be this up and down, swinging back and forth.
I think it's also really helpful to give examples of things to say early on. I think you do that a little bit later with the mirroring and reflecting, things like that.
Yeah.
But I
Yeah.
agree.
Yeah, and just to Deborah's point before, like, just like, and also affected by what it's alluding to, like, simple. Verbal de-escalation is important. It's a very important tool. It can help patients go from very severe to less severe.
Yeah.
You know, you might use it in this situation. You know, they might need intubation and other stuff, but it can still be helpful. This is the way you should
and I get
verbally
that.
de-escalate.
So I guess another example we could bring in is how do you de-escalate a family member who is preventing you from intervening at the bedside. And in that case, someone like a mother who is watching their child, who saw the nurse do something, and
I don't know what you would say, Jim, but I'm thinking you would say the behavioral rapid response team is we're going to be on top of that patient. We'll wait for the psychiatry folks to deal with the family member.
Well, again, it depends. I
Depends
know
if
that
they're intruding.
our target is to call for inpatients,
Right.
but you never know. Sometimes we show up, and at the bedside you might have an angry family member. So that's why the verbal de-escalation piece is so important.
So you think it'd be helpful for families?
Yeah.
does I get a case for that? And the
Well-
pediatrics, I think, especially, is the one of that.
Yeah, okay.
But I guess what takeaway though, I want to get that this idea is you can't. There aren't like certain 5 or 6 things you can say that will work. You have to see meet the patient where they are, and if the patient is in severe crisis, that's why I bring up the psychotic idea again that I've never been able to successfully calm down someone who's just desaturating. It's just a very primitive state. Whereas someone who has some opiate neurotoxicity, they can work. You can work with them.
So the only interventions that I see here, main intervention is verbal and de-escalation.
In this part, yeah.
This part, and then
We're gonna talk about delirium next.
Right, so in delirium, so if someone, you have that patient who got manic on steroids, I mean, he needed medication, he needed security in there to control his behavior, wasn't delirious, but.
that's why I try to be open-ended, but I'm giving these as examples, but it's any time when you see someone is disinhibited or has lost executive function, whether it's from severe bipolar disorder, schizophrenia, or medical illness.
I think the goal is when my team comes in, they're walking away with some tools to verbally de-escalate.
Yeah,
And
Were
whatever,
they all
whatever you
in
have to
the slides?
construct.
Were they all in the slides?
So you like to focus on verbal de-escalation?
I think that's a very important piece of this. So when they go through this training from next month till July or June, they should be able to walk away with being more comfortable in verbally de-escalating. Now, is it for delirium? Is it for non-delirium? Is it for something else? That's the determination
Well,
that.
a lot of them, we're gonna do this in the role play. So remember that there's this, is just the piece, and then there's the role play where you actually do that. But I would suggest, Andrew, is a little bit of this for context, because I think in order to be able to approach it, it's good to know the spectrum. So I think some of it is there, but then kind of talk about in terms of this is background of the ways that people can be, and then here are some specifics in terms of verbal de-escalation, blah, blah, blah. We kind of pare the background down a little bit, but I think some of it's very important.
Yeah.
Because that's how people get more comfortable with the ideas if they understand more about what's happening and how, a little bit more about the behaviors.
Right.
Yeah, I'm with you, Patty. I like the background information. I would keep it, but spend a little bit less time talking about it. But that was very hard to gauge here when we were giving so much
Right.
feedback and cutting you off. So then, and then focusing a little bit more on the examples and strategies for verbal de-escalation. And I also think if we haven't developed already, some paper to hand out for people just to give examples of phraseology or
Card, like when you
Yeah.
That's
have
a very, very good point,
Yeah.
actually, just to have something like that, like a resource that you can look back at.
Did we have did we do a blueprint for this? We didn't?
We circulated something at the very beginning and then never followed
'Cause
through with it.
that's another way, is because with the blueprint, you kind of talk about what strategies are, and then you can talk about examples
Yeah.
of doing that. So there's different ways to do that, but we can.
and also in most of the comm skill modules we have video clips that helps
Right.
people.
We're
see
gonna
things
do
in
that later
action.
on. We're not gonna do this for this initial training because we just don't have time to create them.
Mhm.
But our goal is to have them after the
After,
initial training.
right, but so for this one, I think additional case examples will be helpful as we don't have the video clips.
Most of these scenarios are from real cases.
This is for when we do the role play.
Role play, but to have it
I was
before, to have
thinking,
it
right,
before,
exactly,
yeah.
when you're actually describing the didactic
Yeah,
parts,
yeah.
maybe give an example, specific examples
Sure.
of how you would do things.
Yeah.
But maybe we should review the presentation again before we do the actual?
I think so. I think we need to review the slides again, just so, so we're all on the same page about what message, what teaching we're providing. It would be great if we do that. We can just figure out how to do that before we go in.
Is that something that can be done just via email?
Potentially, at least if we have slides, we have WebEx or something.
Right.
We can go through it together. I particularly, when I do any presentations, I always add an intro slide. This is the focus. Well, this is what I want you to get away with. With the main message is right there, then I repeat that main message at the end, just to kind of tie up things. But again, those are little things, we can go into it later, but I think it's a good idea to refine and review.
Well, let's let Marina talk about delirium so we have a context for both things, and then we'll have to get some additional feedback.
Maybe at least the conference call, I was gonna say, not just email exchange.
Right.
But at least the conference call to go over the presentation.
So
One last comment.
Sure, sure.
I think, I know you're invested in that sort of model of the crisis and stuff like that. I think it's less helpful than what they really need, since you got an agitated patient, all that,
How do we de-escalate? How do we prevent them from escalating? Like, what are some tools? What are some considerations that we need to go in there and just boom, 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 and then in 10,
But
15
you don't think it's helpful to, maybe not all of that, but to understand that crisis does exist on a spectrum.
Of course.
I think
And
that's very
depending on
important.
where
Yeah.
you are in the spectrum, you're going to use, different strategies, right? If you're at the.
well, that's what you should focus on when you say crisis exists on the spectrum. You can say, because it exists on the spectrum, you may move from verbal de-escalation to getting security involved, and then medication and things like that.
Background
As
is good,
opposed
we
to the
appreciate
various
that.
phases of what's happening psychologically.
Yeah.
So it's just something basic like that, like
Yeah,
a
they
crisis,
don't really
crisis
need to
exists on a.
Something
on a
basic, and then when you talk
spectrum.
about the going up and down, they're going up and down, you can say, they might do that, but we're coming to the scene, we're here to, like, that's something we might potentially, address and take over. Like, for you guys are there, you might only have 15 minutes or half an hour with the patient, because you have to think about there are other rapid responses going on in the building. We can't be there for a long time sometimes,
So,
unfortunately.
I just think of the backdrop, so all of these courses, these modules involve some degree of crisis as a spectrum. Anthony Waters, CPI, there's a spectrum that's like the issue is how do we incorporate physiologic changes, because none of us really incorporate physiologic changes into their model, so that's something that could be some help.
Maybe we don't need to.
Maybe we
Maybe we
just
just,
keep it.
maybe we just, crisis, it exists on the spectrum and there are different levels and depending on where you're at or where the patient's at, you try different interventions and then be prepared to backtrack.
Sure.
You might have the patient say, okay, fine, I'll stay, and then something happened and all of a sudden you're back to, that's it, I'm leaving.
But you're always gonna try the verbal de-escalation wherever you go throughout, as you're doing these other
Absolutely,
things
yes.
as well.
Even
because there
with the
still can be
hypoxic
effective.
patient,
Right.
you have to at least document before you're restraining them that
Right.
you've tried it. So yes, you always
Okay.
wanna try to, we have to all be skilled in verbal de-escalation.
Right.
It's like a joint commission. Okay, so delirium is highly prevalent in the cancer population, particularly in our hospitalized patients with advanced disease. It's probably the most common cause of agitation in our patients, and it is a very distressing experience across the board for patients, for family members, and for staff. The DSM, to make the diagnosis per DSM, you're looking for a patient that has fluctuations or alterations in their attention and their awareness. You want to see that this fluctuates over the course of the day, and there's a physiologic insult that is directly related to this change, the cognitive changes. It's a common misconception to assume that a patient that's oriented to person, place, and time, it cannot be delirious. We know that patients that are with delirium more often present with attention and memory problems as opposed to disorientation and psychotic symptoms. These are some risk factors for delirium. Of course, someone who has any kind of pre-existing cognitive dysfunction like dementia, someone who's had a history of delirium on a previous admission, people with advanced illness, multiple medical problems. And I've highlighted some risk factors for delirium that are reversible or easily treated, like dehydration, malnutrition, polypharmacy, or use of restraints. In our setting, there's some common etiologies for delirium. For example, CNS disease, patients who have swelling, cerebral edema, seizures, someone who's anemic, who's got respiratory insufficiency, hepatic insufficiency, someone with something as simple as a UTI versus full-blown sepsis, electrolyte disturbances, or medications like anticholinergic agents, benzodiazepines, or immunosuppressants. We also probably don't screen our patients enough for alcohol use or substances. It can be a common cause of delirium. Delirium is categorized into 3 subtypes based on a patient's motor activity. Hypoactive delirium, for example, is a person who is withdrawn, lethargic, not speaking as much, seems to drift in and out of sleep very easily. This is not the patient that's going to require the services of the behavioral rapid response team. So for today, we'll focus on hyperactive delirium. Hyperactive delirium is, again, it's associated with increased motor activity. It's an agitated patient who's manic-like, they're impulsive. They often are experiencing paranoid delusions or they're hallucinating, which really places them in a terrified, a frightened state. And it's in that frightened state that they have this potential for being violent or aggressive. Sometimes we can see hyperactive delirium present as a refusal of care. Patient admitted, going along with the treatment plan, till all of a sudden they seem to now change. Now they don't want blood draws and they're demanding to leave. What may be under the surface there is that they're cognitively impaired now.
So those are very helpful examples. That's kind of, I think, what we were trying to say in your presentation, Andrew. And even I would define what delusion is, what hallucination is those terms get mixed up very easily. You know, hearing things that are not there, seeing things that are not there, smelling things that are not there. Just to
In the presentation.
specify.
Or, so in the presentation,
In the
like,
presentation,
as we're
yeah,
speaking.
exactly.
So there's a good chance that I won't be giving every delirium lecture, and I'm
So
sure
for
it's
all
gonna
of us, or-
Right, so maybe we could put that in the notes kind of thing.
Yeah, we
Sure.
can always have the notes so that it's consistent. That's what we do in our lectures.
The other thing that might do is when you say delirium is very distressing, you can also maybe just add distressing and frightening.
Okay.
Because I think the thing that these guys need to know is that every delirious patient is just scared to death. And they're acting out of fear. So that's what the aggression comes from. They think they need to defend themselves.
Yeah, so
They
I'm
grab
going
into
fast,
us
but I think
because
we
they
could
just
definitely
Yeah.
hit that point. I'm
Yeah,
flying
you're
through
good,
it, yeah.
you're good.
But yeah. So, the hyperactive delirium presenting with mania is one that we'll spend a couple minutes on. Mania is typically a feature of bipolar disorder, but in our patient population, we actually commonly see it as a result of patients receiving high-dose steroids. So a patient that's delirious and manic will have this elated mood, feel like they're on top of the world. They're very talkative. Their speech is rapid. They're hard to interrupt. Their thoughts are racing. They seem to jump from topic to topic, often not connected. They can't sustain attention. They may have delusional thoughts. Classically, they're known to have delusions of grandeur, where they believe they have special powers or abilities. They also tend to take more risks in an impulsive fashion. So maybe spend all their money or believe that they can communicate with God, or that they can.
They're cured.
Yeah, they can
They
take.
don't need to be in.
They can take chances without getting hurt in the same way someone without these abilities would. And because they're sort of their thinking is so impaired, they have more potential to be violent and aggressive.
I just make this a section. I think for the training, you might say manic symptoms instead of mania, so
Okay.
that people aren't confused that, oh, are we talking now about someone who has bipolar disorder, manic? 99% of the people who present like they're manic, from bipolar disorder, they're actually behaving that way because of some organic, steroids or some other condition. Very rare for someone who has bipolar disorder to come to the hospital and be completely manic. They're usually well controlled on their medicines. So when you see this, it's usually because something medical is happening, steroids, etc. I guess is hyperactivity or agitation in there.
I guess, yeah, I said potential for violence and aggression, increased risk-taking behavior, hyperverbal. I should write hyperactive.
You can probably even take out a feature of bipolar disorder from just saying our patient population most commonly steroid induced or medically induced
We could say sometimes confused
with bipolar disorder.
with.
Or maybe.
So take off a feature of bipolar disorder. So this is a case of a patient that was at our institution not too long ago. It was a 31-year-old male with advanced lung cancer with metastases to his brain. His family brought him to urgent care after they found that for several days he was becoming more agitated, was not sleeping, was talking a lot. They also told the team on admission that he had received a higher dose of Decadron because his CNS disease was worsened. When he arrived on the floors, he remained very agitated. He did not have any insight into his behavior. He started to be completely non-cooperative with treatment, refusing blood draws, refusing to talk to anyone, and really demanding to leave the hospital, standing at the doorway. We were able to very quickly control symptoms by giving him IV Haldol and lorazepam. So in this case, we used the Haldol and lorazepam to manage the agitation, but it also treated the underlying delirium that was presenting, I guess, with, I'll say, manic symptoms. So when you're assessing a delirious patient, you want to have an understanding of what their baseline cognitive status was, and if there have been any fluctuations in the cognitive function over the course of the day. You want to take a close look at their medication list. You want to review any alcohol or drug use history, look at their vital signs, focused physical and neuro exam and lab values. And as you're going through, the chart and the values, you really want to start ruling in or ruling out common causes of delirium like sepsis, respiratory dysfunction, electrolyte disturbance, or a withdrawal or intoxicated state.
You put in the RAS that.
Yeah, I think that was recommended the first time we went over this.
So that one assesses the level of arousal, right? So, that was the only other thing, I was gonna make a comment, you focus on psychomotor activity. One of the dilemmas of disputes in delirium is whether it's purely a function of, whether delirium is a function of a problem with attention, or whether it's a problem with a level of arousal. So the second way to subtype delirious patients is hyper-aroused, hypo-aroused, or mixed, or fluctuate. So the question is whether to add that in some way, not necessarily to give a second classification, because I like the idea of making it simple, and saying they're hyperactive or they're hyperactive. But maybe you say that in the hyperactive patient, the patient is also hyper-aroused, and in the hypoactive patient, the patient is sort of hypo-aroused.
I guess we picked RAS because I think that's like the RRT, like that's the
These are the
ICU
used to it.
language.
And I think it's helpful, because when they see a patient who's
Mhm.
whatever, or fluctuating.
Should I reword it or something in the like
Maybe
in the.
find some way to just link the fact that a hyperactive patient.
So in your assessment, you want to be mindful of their level of arousal?
Can fluctuate, yeah.
Yeah, when you describe the subtypes, you might put parentheses also, can be hyper-aroused, level of arousal is they're hyper-aroused.
Like should I do like a RAS score might be this or a RAS score
Yeah.
might be that? Would that be helpful?
I don't know, maybe when you talk about fluctuations, maybe make a mention, because that's what fluctuation sounds to me,
Maybe you
like
put
we're
it
on
just in
the
the.
spectrum of what you described earlier about the, like hyperactive, hypoactive, and mixed, and sort of, I don't know, I sort of got that from.
It's confusing to add the arousal.
No, I think it's just, we kind of already know all of this stuff.
You don't have to know it all when you.
Yeah.
Okay. Maybe you put it in there when you include the RAS, and just say.
Level of arousal.
Yeah.
Are they hypo-aroused or hyper-aroused? I mean, that's something that I could write in the notes for the presenter to talk about. So further workup can be extensive, but it really, these tests should be guided by the history, by your physical exam findings and the results that you've received on your initial workup, and of course, always within goals of care, consistent with goals of care.
Quick question, Siobhan. You guys will not be doing all that stuff, right?
No, I think
So the
some of the
question is-
stuff, the basic stuff, yes, but some of the more comprehensive stuff, again, it's, the messages will be there, will help,
Yeah,
we'll
I
sort
think
it out.
this is like a 2-second slide. This is
what you
this
do.
could be
The reason
yeah.
I'm bringing it up, is it worth it to suggest tests that the rapid response team might think of doing? Like, what would you do to tell them, see if a patient,
So-
what might you do? Nothing, really?
I think it depends on the clinical scenario and the clinical situation. I think most of our team members will be pretty good about ordering, if they think the patient's hypoxic, they'll be drawing lab work,
I
CBGs,
think
X-ray.
they're gonna be better at knowing what they need to order and their workup than you're
Yeah,
gonna.
I think the bullet point is, again, think about delirium, what can we do to the underlying cause, just think about these things. I don't know, Deborah, what do you think?
No, just can you move forward to the workup? I would eliminate the basic stuff and even like the TFTs, because honestly, that when in sick patients is very unhelpful. I would focus on drug levels, maybe getting thiamine, B12, and folate. But even that stuff, it's not going to come back for such a long
Right.
time as to be
I don't
relevant.
think
But
that-
that's what I would focus
Yeah,
on.
we didn't
Yeah,
intend this
I
to
don't-
be something
yeah, I
that a
don't-
real rapid response team
Right,
was
and
doing.
it's there's no like algorithm for you order this or that, it's really, it's gonna depend on each case. I
Mhm.
guess the point that, when you look at delirium lectures, they always talk about there's an initial workup and then there may be further tests.
Yeah,
right?
my point was just that we would get all of that stuff, but like the really specific stuff, like that's what I would keep on here, and
Yeah, so maybe there should be a slide before the further workup, what's like the immediate workup. Is that right?
I would just do,
Yeah, but that might be enough.
I mean, it's vague, you know, lab values and imaging, because it's gonna really depend on who you're seeing, right, what,
Mhm.
you know, what kind of patient.
I mean, again, you know, if you have somebody with Wernicke's encephalopathy, hopefully, you know, maybe we diagnose it within the 10 minutes of being there, but again, you don't have a lot of information, you don't have an MRI.
Right.
You know, we don't have the blood levels, and maybe not even a history to put everything together. You know, it's something the experts will be there helping us out
I
with.
think this is probably the expectation of the RRT would be
Mhm.
some initial lab work, some initial vital signs.
See, what I would include for the behavioral rapid response to in terms of assessment is the patient confused, disoriented? Do they appear to be hallucinating? Do they seem to be responding
Okay.
to some kind of, you know?
What I think is
They
also
look like
helpful, I
they're,
don't know if you
yeah,
plan to
hearing
cover it,
voices.
and again, you know, Sloan Kettering is a very different population, but I do think it's helpful to maybe have a slide or two on how people, when they are withdrawing from alcohol, what are some signs and symptoms in terms of day one, day two, you know, a little bit about, you know, whatever the pathological manifestations are, you know, for alcohol withdrawal. Now, you know, just a little bit, because you never know, or substance abuse, this is what you might
Yeah,
see.
they have asterixis.
So you think I should put a slide on what alcohol withdrawal?
I put it in a list of the things that you want to be looking at. Is the person hallucinating? Do they seem to be, are they visually hallucinating? Do they look like they're hearing voices? Are they looking at things? Do they seem paranoid? Are they tremulous?
Right, for example, somebody with a significant drinking history, okay, these are few things, this is something that's important to get as part of the story. You know, you
The
think
kind of things that we do when we walk in the room. and go,
Yeah, sure.
Oh,
So maybe in
There is
addition
the
to
withdrawal role play though, is that something?
Yeah,
that would be
that's one of
addressed
the
at the role play as
scenarios.
opposed to in the room here?
No, it's
That's
good to have a
true.
slide. I think the role play is good, but if you have something on the slide, like just to the point, I think it's always
Okay.
helpful.
If that's major, that would change your intervention.
Yeah.
The alcohol
Yeah.
related versus other delirium.
Yeah, and Deborah and everyone else, can you think of other clinical scenarios that
What
we can come back to it, but
I definitely want to keep going to
Going
be
on
able to get to the
track,
role
yeah.
play, because I think this is the
Sure.
kind of stuff that we can also discuss over a conference
Sure.
call, but
yeah.
I'm a little concerned about time right now.
No, thank you for
Yeah.
keeping us on track. especially
I'm
because
trying.
I'm the one that has
We're
to
like way behind,
leave
but
early.
So with delirium, the first and foremost thing you want to do is really identify and eliminate the physiologic cause. There are some non-pharmacological interventions and pharmacological interventions, both of which we'll go over today. So non-pharmacological strategies like increasing supervision, treating dehydration, assessing for respiratory function, treating any infections, pain, careful review of their medication list, improving nutritional status, promoting good sleep. I guess those are all things that are shown to reduce rates of delirium, non-pharmacological interventions. And for pharmacological interventions, right now, we have evidence, our evidence supports the use of antipsychotics, short-term and low dose, with very close monitoring of adverse effects, particularly in our patients with advanced disease or severe disease and our older adults. We don't have, although antipsychotics are associated with some risks, we don't have evidence that shows that any other psychotropics, psychotropics are any medication that's used, how would we find, mood altering or?
CNS active.
CNS active medications. So no, we don't have evidence to suggest that any other agents besides antipsychotics are safe for managing delirium. So when you're managing an agitated patient, the first thing you want to always attempt is verbal de-escalation. When you feel that the person is escalating, they are now at a point where they're at acute risk of being harmful to themselves or someone else, this is a medical emergency. And in this context, you are permitted to administer medication to control the agitation, even if that person objects to it. You want to be sure, if you're sort of crossing that bridge, you want to make sure that you are documenting what harmful behaviors you're seeing and what less restrictive approaches you've tried. Like we tried to sort of have a discussion with the patient. We tried to have family come and help, but they are continuing to be agitated and threatening. And at this point, we think medication is the safest approach. Let's talk a little bit about commonly used medications. Again, antipsychotics for the management of agitation. Haldol is probably the gold standard therapy for delirium. It's very useful because it's available in IV and IM preparations. You can combine it with low-dose lorazepam if you've got a patient that's very agitated. And again, lorazepam can also be given IV and IM. At high doses, we worry about extrapyramidal side effects, or these are those Parkinsonian symptoms. People can be very rigid, they can become restless, develop a tremor, or on the more severe ends have acute dystonic reactions or neuroleptic malignant syndrome. That's where they develop lead pipe rigidity, fevers, and altered mental status. You also want to monitor for QT interval prolongation. So maybe taking a quick peek at the most recent EKG in the chart and looking at the QT interval, and then when the patient is calmer and you're able to do another EKG after the Haldol's been given to follow up on it. Chlorpromazine is another good choice for the very agitated patient because it's quite sedating. And it is also available in IV and IM preparation. Just be mindful that if it's given IV, it's infused over 15 or 30 minutes, so you have to decide if you've got that flexibility time-wise. It is sedating and it is more anticholinergic compared to Haldol. The big thing with chlorpromazine is that it can induce hypotension. So if you're using it in high doses, you want to make sure your patient's in a more monitored setting where you can keep an eye on blood pressure. So the rest of the medications I'm going to talk about are only oral. So these are medications so you've got to have a patient that's a little bit more agreeable to kind of be taking something by mouth.
Can we speed through these ones, or are the medication ones, or do we need to?
I guess. I mean, I'm just
Right now, let's.
We'll just. I mean, it's just.
It
the side
feels
effects.
pretty big, yeah.
So.
It's very good information.
Yeah.
Okay.
So.
I like that.
It's important.
It's important.
Absolutely.
Well, if you want to go through it, that's fine. I
No,
just
no,
figured
you
that
don't
was
need to.
I
easier.
think
It's very
but I'm
clear.
saying it's very good to keep.
Yeah, okay,
And I
great.
think during the
So this is what
actual.
I'm thinking. So if you go back, so a lot of the information is very helpful in terms of the overall treatment of delirium. But I think what we need to convey to the training is, okay, these drugs are very helpful, but the behavioral rapid response team is called, if you have an agitated delirious patient, this is what we recommend you
So
do.
maybe this is sort of an algorithm.
Right.
I think this is what we would expect you do. You try verbal de-escalation. Attempt to offer the patient PO medication, and those are some agents that you could offer. If you're failing there, then the first thing you would turn to would be IV Haldol. And then and combine it with IV lorazepam if the person's severely agitated. And if that's failing, then turn to chlorpromazine.
My only thought is that if they're calling a behavioral RRT, we've already passed the PO medication option.
Yeah, you're not gonna use, so.
Well, they might have gone 15, 20 of Haldol already.
So for instance, I would give them very clear instructions. You get called, right, got a really agitated patient. If you're above, I don't know, if you're a big guy like me, you give that person 5 milligrams of Haldol plus 2 milligrams of Ativan, IV or IM, whatever you get it.
So how do
If
you?
that patient's already gotten 20 milligrams of delirium, of Haldol or whatever, or they've already gotten 10, go to chlorpromazine and give that person, an IV bag, give them, if they're a big guy, give them 100 milligrams IV over 20 minutes.
Maybe,
Yeah, 50 milligrams if it's a little old lady, something like that, very concrete.
maybe,
Right.
I
Because you're not
wonder,
gonna give somebody a land, if you get called, you're not gonna give somebody a landscape.
No.
So that's,
No,
maybe
take
take a
what
look
you're
at the role
but
plays
you
because
wanna,
there are
but remember, when
situations.
you're giving someone, chemically restraining someone, there's supposed to be some documentation in the chart that they would not take anything less restrictive. They couldn't be talked down, and they wouldn't accept medication PO. So that's why we're chemically restraining like this.
Yes,
And
you
that's
need to-
really,
And you wanna double check when you're called, just make sure, I mean, you don't know exactly what the
If you've
circumstances
got
are.
a patient who's very agitated, who's a
yes.
threat to themselves and others, you've got a medical emergency.
Absolutely.
And you can give them what's necessary to treat them.
But
So
but
you think you need any
well,
more explanation than that?
but you always have to document what least restrictive, thing was offered and failed.
Right, but I would also say that it's not safe to give them PO medications because of the time to onset of action, like, it just
Yeah,
takes
so
too
but-
long.
but-
So I would mention that like in your documentation, be sure to mention
And I mean, I think
this
always,
aspect.
even for the very agitated patient, if you can get them to take something by mouth, I mean, that should be our preference, right? We shouldn't.
And our notes would, most of our notes, they're very thorough, will justify, like, we'll explain what happened. And then, if somebody wants to review the chart, they'll understand, it's very obvious why we did not offer them Zyprexa. It'll be obvious.
But I think this is also an opportunity to offer a choice too, which I don't think, even if you said, look, we have to give you some medication, calm down, here's your option, it's sort of like you can have the mommy or daddy give the toothbrush type scenario, like.
I think the choice is are you gonna allow us to give you the medicine? I think, or do we have to hold you down?
I don't know.
I don't
That's
think
the
legal would
choice.
like this saying that.
I don't think anybody will say yes when we get home, but.
I mean, when I think about the patients that I've been involved with over 30-something years where we would have had to call a behavioral rapid response team, these are people out of control, dangerous, this and that, they've just attacked their nerves, you gotta get them chilled out quickly.
Maybe like the presenter can kind of say, we recognize that by the time this is escalated to the behavioral response team, you're probably not at the point where you're gonna realistically be offering medication by mouth, or you're gonna assume that that's already been tried and failed, so you're probably at the point where somebody should be starting to draw up Haldol or draw up chlorpromazine.
But I agree with you that I think it's important to still go through that, remind people that that it's a process, and that you want to have,
And then I wonder if talking about specific doses and things like that might be something that we could do when we're in the role play. So we'll have a case where there's a.
I think it's very helpful for them to have it in their slides, right?
But there
But
might
what
be
if we put
situations,
something
yeah.
like 10, give 100 of chlorpromazine, and then they give it, then it's given to a patient you wouldn't give it that, wouldn't give that dose.
I think you have ranges in there, so I
you don't want to, you can't
think that's
be too
okay.
prescriptive.
You can,
Right.
the reason to have a behavioral rapid response team is to get that person chilled out.
But we have cases.
Not dangerous.
Yeah, we have cases though where we have patients threatening to punch out attending, not because they're disinhibited, where they need to be offered an option of PO, not because, they're not threatening because they're delirious or disinhibited, they're just.
I'm talking about a
Well, we're
really
talking about
badly
delirium right
delirious
now.
patient,
Right,
I mean, if you give that person a 0.5 milligram of Haldol and a 0.5 milligram of Ativan, you basically got the same agitated patient sitting there. These guys are like at risk for being hurt.
So maybe, what if I just put in 2 brief examples, put like a,
Good,
40-year-old
that's good,
man, large
Right.
size, who's,
Yeah.
menacing
And a
or
little
something.
old lady, yeah.
Right, and a little old lady, and I'll show the different doses.
Or even that 4 patient we recently had, he wasn't too large, but very agitated because of the brain tumor.
So already received 10 of Haldol and not
Exactly,
improving, and then
exactly.
you're gonna choose
Or
from this.
security, several
Okay.
staff members
So
allowed
I
still.
could put in 2 case examples like that, where just
Mhm.
different approaches, one very low dose and one you're gonna go like big guns.
Can I ask a question? I know I saw your last line, that means you're done with, right, you were pretty much.
That would be the
eliminating
medication
right?
part, and then I was gonna briefly talk about restraints.
Okay.
but that was it.
Now, just, are there certain situations where somebody who has behavioral disturbance is getting Haldol or whatever type of mood stabilizing drugs, where they can have a paradoxical reaction or some kind of reaction where they're exhibiting an altered mental status state that we might get called for, like a rapid response, whether, you're talking about
Serotonin
extra.
syndrome or
Right.
IOS.
Or
Yeah.
akathisia.
Pardon? Am I right?
Akathisia, they get very restless from antipsychotics.
Right, so, again, we can talk about this after, but maybe a slide on that or two, just
Yeah.
somebody that's known to have psych disturbance, has gotten a lot of this stuff, and these are some characteristics of these conditions, just so you guys are aware.
That's interesting.
Yeah, that actually happened very recently with an older guy who received lots of Haldol, getting increasingly agitated and calmed down after Ativan.
So is it not enough to talk about it in like the side effects? I mean, should we, maybe the presenter just emphasize more what
These side effects can happen with most of the
So
But there's some that are
a lot
more
of these
bigger
side effects
culprits.
happen over a long period of time, but there are some that are acute. And I think you guys wanna know about the acute effects when you're giving it. But I think Jabron's also saying, let's say there's someone who we're treating for delirium, and then suddenly they start to get agitated again. And it turns out they're apathetic, or they have NMS.
Right,
So
I know, right?
serotonin syndrome.
Yeah, or serotonin,
Yeah.
just again, it's important because, when we think of fevers, there are non-infectious reasons for fevers, and
Or
you
acute
can't always think sepsis. Most of the time it is in our patient population, especially if they're not on these drugs. But a slide or two, just, because I think if you're
So
covering.
maybe a slide on serotonin syndrome and one slide on
Neurological.
NMS?
You can put it all on one thing,
Yeah.
Let's, I think a lot of the didactic stuff we can work
Yeah.
out in a conference call.
Yeah.
Let's go through the role plays and use our
Yeah.
actors that are here.
Can I just go to? is there-
No.
Yeah, why don't we take 5 minutes and then,
The verbal
5 minutes.
de-escalation, as we really want to emphasize it in your slide where you have the algorithm, can that be like an overarching?
Irish soda bread for everybody for
Aw.
St. Patrick's Day, so I'm gonna put it on the table outside.
She didn't have any
When is St. Patrick's
That's your
Day?
point.
Done Saturday.
Yeah, so I think from a medical.
Should be a part of, yeah.
It's sort of medical legal side, like here's the layers that we have to document, but then
I know.
I think technique wise, we should always have.
I mean, I guess,
I know, me too. Sure.
What if you had a